Good afternoon, everybody. Welcome to our live Facebook question and answer session about parathyroid disease. I'm going to give people maybe another minute to log on and join us. For those of you who joined us a couple months ago when we did our last one, I apologize for the technical difficulties we had with the volume. Hopefully that's been fixed for this session. If you notice any problems with that, obviously write in so that we know. Just quickly for people who haven't joined us before, a little bit about who I am. My name is Dr. Jamie Mitchell. I'm the medical director at the Norman Parathyroid Center in Tampa, Florida. It's a practice dedicated entirely to the surgical care of hyperparathyroidism. We operate at the Hospital for Endocrine Surgery. It's a one-of-a-kind hospital dedicated entirely to the care of the endocrine surgical patient with a parathyroid center, a thyroid center, and an adrenal center. Quickly about my history, I did my undergrad training or education in a small Jesuit school in Massachusetts called Holy Cross. I went to medical school at Georgetown University and did general surgery training in the Harvard University training program in Boston. And then I did fellowship training in endocrine surgery at the Cleveland Clinic, where I began my career as an academic surgeon for about 8 years. Then I left that practice to join the Norman Parathyroid Center in Tampa. And I've been here for 10 years. And with that, I think we've given people a chance to join. And thank you to everybody who sent their questions in ahead of time, a lot of great questions, and hopefully we'll be able to get to all of them. If you have some questions that come up while you're online, feel free to write them in. And if we have time to get to them, then we will. So let's get started. Question number one. This is an interesting question. What's the best way to manage parathyroid disease during pregnancy? There seems to be little information available. It's a really good question. While most tumors or other diseases that are diagnosed during pregnancy often are delayed, or the treatment is delayed until after delivery, with hyperparathyroidism, it's best to actually treat the disease right away. The safest time to do it is during the second trimester. This is often the safest time to perform surgery or expose the mother and the fetus to anesthesia. The reason that it's advocated to treat this during the pregnancy is that hypercalcemia that comes with hyperparathyroidism can increase the risk of preterm labor and the complications associated with that. So with pregnancy, if it's diagnosed in the first trimester or second trimester, the best approach is to proceed with surgical cure during the second trimester. Great question. Okay, next question. My sestamibi scan was negative, but my PTH and calcium are still high. Does this mean I don't need surgery, or are other imaging tests more reliable? That's a really good question, and it's a topic that comes up over and over again with the questions that come in. To be clear, imaging tests are not diagnostic for this disease. They are not useful in making the diagnosis. The reason for that is the technology that exists even in 2025 for imaging abnormal parathyroid glands is simply not very good. Traditional imaging tests, the most common, include sestamibi scan, like this person wrote in with, ultrasound examination of the thyroid in the neck, and CAT scans. These are the most common imaging tests that are utilized, but none of them are really very good. Because of that, imaging tests are not useful at all in making the diagnosis of hyperparathyroidism. They should never be used that way. The only thing that matters is your biochemistry, so your lab data, calcium and its relationship to parathyroid hormone. That is the only thing that's important in making the diagnosis and knowing that you have hyperparathyroidism and need surgery. Imaging tests are a tool that are utilized perioperatively, and we use them as well, but it's not and should never be used to make the diagnosis. A common error that we see made all the time is that a patient or their doctor will note high calcium, they'll do a workup and actually make the diagnosis of hyperparathyroidism, get an imaging test like a sestamibi scan. The scan will be negative, it won't show anything, and they're then told, oh, you don't have this problem, you're fine. That isn't the case. Don't fall into that trap. Okay, imaging tests do not have a role in making the diagnosis. Okay, are other imaging tests more reliable? The answer is no. None of them are really very good. Let's see. This is a bit similar. If sestamibi scans are often negative, have you ever operated on patients and found no parathyroid disease? Do normal calcemic patients run this risk? Yeah, probably half the patients we operate on the imaging tests don't show much of anything. A portion of the other, half of patients where the imaging tests do show something, those are false positive results, meaning the signal or the finding has nothing to do with parathyroid tumors. And so it's important to have we feel it's important to have an approach to this operation where we don't use imaging results to guide the surgery that we do in most cases. Occasionally there are unusual findings that do change things, but the majority of the time, 99% of the time, the results of imaging tests that we do not change the operation that we do, which is to identify and evaluate all 4 parathyroid glands regardless of the imaging results. Do we sometimes not find parathyroid tumors? Yeah, that happens. It's pretty unusual. It's less than 1% of the people that we operate on, but some patients have tumors in locations that we cannot get to unless we know where they are, and they just simply don't show up on the imaging. As I mentioned before, imaging has limitations. So it's an unusual circumstance, but it does happen. Here's another question. My endocrinologist recommended vitamin D, but I've heard it can worsen hyperparathyroidism. Is it safe to take this? A couple things about this. This is another common issue that comes up. It's important to know that if you have high calcium levels and high PTH levels and low vitamin D levels, and that's usually the case, vitamin D is typically low when you have hyperparathyroidism because parathyroid hormone is converting it to a different form, so it's depleting your vitamin D levels. And so it's often low. Often we'll see endocrinologists who see this pattern of labs, high calcium, high PTH, low vitamin D, will tell their patients, let's replete your vitamin D and see if this corrects your high calcium. That is, that's muddy thinking. It doesn't make any sense because while low vitamin D or vitamin D deficiency can increase or elevate your parathyroid hormone levels, that's something that's expected. Vitamin D deficiency never causes hypercalcemia. So if your calcium is high and your doctor tells you to replete your vitamin D to see if it fixes that, don't do it. Taking vitamin D is usually not dangerous as long as you're not taking a ton of it. So if you're taking 1,000 or 2,000 units of vitamin D per day and you have high calcium and high PTH, it's probably okay. It's not going to make your calcium worse. If you take a lot of vitamin D, however, that can be dangerous and can make your hypercalcemia worse. In general, we usually tell our patients to just not take the vitamin D because it usually isn't helpful. It's a good question. This is a complicated question. After a right thyroid lobectomy and parathyroid adenoma removal in 2011, I had injury to my recurrent laryngeal nerve and ICU admission. My calcium and PTH remain unstable and I have suspicious thyroid nodules. Endocrinologists or my endocrinologist tell me that another operation is too risky. What do you recommend? This is a complicated situation. When you have injury to the recurrent laryngeal nerve, which can happen in any of these neck operations, parathyroid surgery, thyroid surgery, cervical spine fusion operations, that puts this nerve at risk. In experienced hands, the risk is quite low, but it can happen. If you have a paralyzed vocal cord, it can affect your voice and sometimes can affect swallowing to some degree, but it's something that you can live with. If you have 2 paralyzed vocal cords, then that's a big problem. Usually you cannot breathe without a tracheostomy. So if you have to operate on the other side of the neck when you have a paralyzed vocal cord on one side, it's a complicated situation, but is it manageable? Yeah, it is. In experienced hands. At this point in my career, I've been doing this for 20 years, I've had to operate quite a few times on patients who have had that problem. They have a paralyzed vocal cord from other surgeries and they need to have an operation on the other side. And every time I've done it, it's been successful and the patient's done fine, but there's a certain approach that we have to take and there's certain things that we have to discuss in terms of risk. But it's not correct to say that there's no options for you. So I would recommend seeking out an experienced endocrine surgeon, like our practice, for example, if you have these problems and require another operation despite a paralyzed vocal cord. So this is an interesting question. I have persistent hyperparathyroidism-like symptoms, but my calcium isn't extremely high. Could I still be a candidate for surgery? It's an important question. Let's assume that your calcium is normal. So if your labs are normal and you have a lot of symptoms that are similar to hyperparathyroidism-related symptoms, which frankly are non-specific type symptoms. Symptoms are not diagnostic of hyperparathyroidism. They are too non-specific. So without the biochemistry to support the diagnosis, having these symptoms is not an indication for surgery. You have to have lab data that confirms or at least raises suspicion for the diagnosis of hyperparathyroidism. We would never take someone to the operating room based on symptoms alone, okay? Isn't extremely high. Let's say your calcium is high, but your doctors are telling you, oh, it's not high enough to have surgery. If that's what we're talking about, that's another good point, because your calcium doesn't have to be extremely high to be a problem. It only has to be high. It isn't how high or how much above normal the calcium levels are that matters. It's how long you've had hypercalcemia that's the problem, or indicates the severity of disease if you have hyperparathyroidism. So if your calcium is high, but not extremely high, yeah, you're a candidate for surgery if you have biochemical evidence of hyperparathyroidism. If your labs are normal, but you have these types of symptoms, then they're likely coming from something else. Okay, next question. I had 2 parathyroid adenomas removed at your center in 2014, so quite a while ago. I have continued to take calcium supplements since. My labs have been normal. Do I still need calcium? There's 2 reasons that we give patients calcium after successful parathyroid surgery. In the short term, number 1, calcium tends to run low for a couple of weeks after successful surgery. There's a couple of reasons for this. If you have a single parathyroid adenoma and 3 normal glands, however long you've had the disease, your normal glands have not had to do anything. They have not been working or making hormone. And so once the tumor is removed, those glands that have been suppressed for however long you've had it, usually years, it takes them some time to start producing hormone again. And so that's one reason that calcium tends to run low. You don't have parathyroid hormone being produced at a normal level to support that. The other thing that happens is when you have parathyroid disease, you are losing calcium from your skeleton constantly. And once it's corrected, that process reverses almost instantly, and your skeleton starts to siphon calcium out of your bloodstream, because it can for the first time in a long time. And so your calcium levels lower because of that in your bloodstream, because your skeleton is sucking it up out of the blood, and you don't have parathyroid glands. Your normal glands are not able to produce parathyroid hormone to counteract that. And so calcium tends to run low in the short term for a couple weeks. We give calcium supplements to counteract that. In the long term, if you have evidence of bone loss, it can be beneficial to take calcium supplements for a period of time, depending on how bad your bone loss is, to provide substrate for your skeleton to rebuild itself, which it often does after successful parathyroid surgery. So calcium supplements for a couple years after surgery with a multivitamin and staying physically active is a good way to help your skeleton rebuild itself. But if it's been 10 years, you're probably not getting a ton of extra benefit from taking the calcium supplement, so it's fine to stop. Next question. If my last remaining parathyroid gland needs to be removed, what are the long-term treatment options? So that's an interesting question. Let's assume someone has, I don't know what the circumstances of this patient are, but if a patient has parathyroid hyperplasia or they have 4 abnormal glands, to treat that problem, we do what's called a subtotal parathyroidectomy. That means 3 of the glands are completely removed, and depending on how big it is, sometimes part of the 4th is as well. We always leave part of a gland behind, because the goal of any parathyroid operation is to, number 1, cure the hyperparathyroidism, right? But do that while preserving normal parathyroid function. And 4-gland disease is pretty unusual, but we see it, and that's what you have to do to fix the problem. Part of the problem with that is that the gland you leave behind is abnormal, and so over time, usually a long time, but that remaining gland can cause the disease again if it gets big enough. If that happens, we don't remove that gland completely. What you do to treat that is you debulk that last remaining gland, meaning you take part of it out again and you still leave a little bit behind. So it's a treatable problem. Usually not that complex to do, but that's how you manage that. Let's see, let's go to the next one here. It's all right. Okay, I had parathyroid surgery many years ago, 30 years ago. In the last few years, my PTH has risen to 160, but calcium is normal. My doctor says I don't need to worry. Could I still need surgery? Without seeing your lab data, it's hard to know for sure. There are reasons that don't mean parathyroid disease that can cause your PTH to be high. So it's important to know exactly what your calcium levels are. What does your doctor mean by normal? And that's an important point because most calcium assays will list the normal range up to 10.5. But for most adults above 40, anything above 10.0 is really elevated, and 10.5 definitely is. So if your doctor's looking at your lab data and it's 10.4 with a PTH of 160, that means you have hyperparathyroidism. Really anything around 10.0 or above with that high of a PTH means you have recurrent hyperparathyroidism. And it does happen. People can have recurrence, especially after 30 years. So I would be clear about what the calcium is and what they mean by normal. If it's above 10 with that high PTH, you probably have hyperparathyroidism. If your calcium is 9.0 with that PTH, then your doctor needs to sort out common causes for secondary hyperparathyroidism or a secondary PTH elevation, because often that's managed medically, not surgically. This is a question, is there a known link between lupus and hyperparathyroidism? There really isn't. There's been some case reports about an association between lupus and hyperparathyroidism, and lupus in rare cases has been shown to cause hypercalcemia, but it's not neither are very common, so there really isn't a strong link that's known between the two diseases. Next question, if both calcium and PTH are elevated, does it always indicate hyperparathyroidism or could something else be causing it? The answer is yes. If your calcium is high and you have a high PTH, that is hyperparathyroidism 100% of the time. There really isn't anything else that can give you that combination of lab data. The only thing that I would say is that, I would say almost 100% of the time actually. And I hate to get into this because it's a tricky concept, but there is something out there that the endocrinologists always are interested in trying to rule out, and it's a familial syndrome that can mimic the biochemistry of hyperparathyroidism. It's called familial hypercalcemic hypocalciuria. And these patients can have high calcium and high PTH values, but the reality is it's pretty rare. It's very difficult to definitively diagnose this. They use 24-hour urine calcium levels to try to sort that out, but even that isn't that accurate. There's a genetic test you can test for this, the calcium sensing receptor gene mutation. Even that is not always accurate or definitive. So the truth is, unless a patient comes with a strong family history of calcium and PTH being high, 5 or 6 family members, especially when one or more of those family members have had routine surgeries where the lab data does not improve at all after surgery, that's when I start to think about that. But it's a rare situation. In most cases, if your calcium and PTH are high, then you have primary hyperparathyroidism. Let's see, here's a good one. I was diagnosed with primary hyperparathyroidism and prescribed hydrochlorothiazide. This is a thiazide diuretic for a urinary calcium leak. My 24-hour urine calcium is 360. That's elevated for those of you who are listening. Serum calcium is 10.5, PTH is 80. Those are classic labs for hyperparathyroidism. Is hydrochlorothiazide typically used in managing this condition? With your labs, the answer is no. We're talking about two different things here. Okay, primary hyperparathyroidism, and that's what you have. Your lab data is clear. The 24-hour urine calcium being elevated is just part of it. Urinary calcium leak is a separate thing. This is something that we have to rule out when people have normal calcium levels or low calcium levels and a PTH that's high. When we're trying to sort out if a patient has normal calcemic primary hyperparathyroidism or secondary hyperparathyroidism, renal calcium leak is one of those things that we have to make sure the patient doesn't have. And they typically have low calcium, high PTH, a high 24-hour urine calcium, and they usually make a ton of kidney stones. Hydrochlorothiazide is used to treat renal leak syndrome, but if your calcium is 10.5 with a PTH of 80, you do not have that. So frankly, I would stop the hydrochlorothiazide. You have primary hyperparathyroidism and the thiazide diuretic. And the way that diuretic works is you pee out more sodium ions in exchange for holding on to more calcium ions in the blood. All that's going to do is make your calcium levels higher. So I would stop that, actually. That's an interesting question. Let's see, where can I find the most up-to-date information on hyperparathyroidism? I mean, at the risk of being sort of egocentric, I would say go to our website. It's very comprehensive, and you can find pretty much anything you need to know about the diagnosis, the treatment of hyperparathyroidism, etc. Okay. There's another part to this. My endocrinologist only prescribes vitamin D and calcium. I want a more comprehensive approach. I'm not sure, it depends a little bit if you have secondary hyperparathyroidism or primary, but to find out about the two and the distinguishing features between the two to understand what's going on with your case a little better, try to check out our website. It's parathyroid.com for those of you who don't know. Next question, how common is it for a parathyroid tumor to be missed during surgery? It depends. If you're talking about our practice, that's pretty rare. It does happen. As I mentioned before with one of the other questions, there are, based on the embryology and anatomy of parathyroid glands, they're not always in accessible locations. They can be in the chest, they can be in unusual locations that unless we know about it with imaging, which is not very good, as I said before, sometimes we just can't figure that out. There's no way to do that. How often are parathyroid tumors missed by inexperienced surgeons? This happens all the time. We see it because they have unsuccessful surgeries and then they come here. So I guess, one of the important points of this question is how important it is to have this operation done by an experienced surgeon, someone who does a lot. 10 a year, 5 a year, 30 a year, that's not very much. So you want to find a surgeon who does quite a few, hundreds of these per year. After goiter surgery, all 4 of my parathyroid glands were accidentally removed, and I now manage hypoparathyroidism with medication. Are there options for gland replacement or stem cell therapy? That's a tough problem. The short answer is none that I know of. Parathyroid transplants in certain very specific situations have been tried, but none have been successful that I'm aware of. So there's no great therapy for hypoparathyroidism. There was a medication that was on the market, but it was taken off, called Natpara. It didn't work that well, to be honest. I do believe there's a new medication that's out there, although I'm not that familiar with it because it's quite new. But in general, if you have hypoparathyroidism like this, calcium supplementation, vitamin D supplementation, quite a bit of it is required to kind of manage things. Let's see, anything else coming in? Okay, here's some more that have come in. How long does it take for a bone scan, or to be clear, a DEXA scan is really what we're talking about, because a bone scan is a different thing. How long does it take for a DEXA scan to improve after surgery? It doesn't happen overnight. It's a slow process, and it's pretty variable, to be honest. While there's really good data that successful parathyroid surgery will result in an increase in bone density, a lowering or an increase of your T-scores. It's variable. Well, bone loss is often a multifactorial problem, and so every patient is their own unique situation, and so everyone's a little bit different. But most patients do show some improvement in their T-scores, but it's usually that improvement is shown over the ensuing handful of years after surgery. But it's important to realize that not everybody shows a significant or even any improvement in their T-scores. But what is important to know is that regardless of what the T-scores do after surgery or how much they improve, what happens instantly after parathyroid surgery is that the accelerated bone loss that all that extra parathyroid hormone is causing, that stops instantly. So it's still a benefit to get the surgery done, whether your T-scores improve or not. Here's another one. My calcium is 11, so that's clearly high, but my scans are always negative. I'm symptomatic. I'm afraid of surgery because I'm a singer. What should I do? The short answer is you should have this treated. I have to say, it seems like everybody's a singer. When I operate on this, everybody's a singer. They sing in the shower, they sing in the choir. I've operated on some professional, some famous singers. And the truth is, everybody's voice is important. So, it's not like we're more careful when someone is a singer, etc. We're always incredibly careful when we operate during these operations because we operate near the nerve to the vocal cords, as most of you probably know. The short answer is there's no way to have zero risk of voice changes with this operation, even in our hands. It's really rare. It's a fraction of a percent. And voice changes that occur in this practice are almost always temporary, but there's a risk of permanent voice changes. If you're a singer and that's how you make your living, I can understand having anxiety about the operation, but the risk for voice changes in experienced hands. So what should I do? Find a very experienced surgeon. I don't think there's anyone more experienced than the surgeons in this practice, so consider coming here if you decide to be treated. But the benefit of treating this, the problems that this disease causes for you, the really tiny risk of the operation, the benefit for you outweighs that tiny risk. So you should consider it. Okay, I think it's the last question. Can a parathyroid gland be bad, quote unquote bad, without the presence of a tumor? The answer is yes. The disease, hyperparathyroidism is usually caused by a benign tumor, an adenoma developing in one of your parathyroid glands. That's the most common reason for this disease, but there are some people who have what's called parathyroid hyperplasia. It's a different pathology that affects all of the glands, and the result is the same: overproduction of hormone, hypercalcemia, and the complications that come with it. But the problem is spread out over all 4 glands rather than a tumor growing in one gland. So hyperplastic glands that are overfunctioning are just as bad as tumors. They cause the same problem. But the pathology is a bit different. Okay, I think that's all the time we have. So thanks everyone for joining us again. And again, thank you to everyone who wrote the questions in. And it helps everybody, your questions add to everybody's knowledge who joins. So thank you for that. We'll be doing another one again in another couple months, and we'll post when that's going to be. And for those of you who missed this, it'll be on our YouTube channel. So thanks for joining us. Until next time, have a great rest of your evening.